So it's also my great pleasure to introduce our second faculty today, who is Dr. Somashekar Krishna. He is a professor of medicine at The Ohio State University Wexner Medical Center. He trained in advanced endoscopy at the University of Texas MD Anderson Cancer Center. His specific research interests include advancements in endoscopic ultrasound, techniques including in vivo confocal laser endomicroscopy, or CLE, to evaluate pancreatic neoplasms. A majority of his clinical practice is devoted to managing patients with pancreatic cystic lesions. And as a principal investigator, Dr. Krishna successfully received competitive funding at the national level in terms of how to specifically manage pancreatic cysts. He completed a prospective single-center study called the INDEX study and is leading a multi-center prospective study for the diagnostic evaluation of cystic lesions currently. Please join me in welcoming Dr. Krishna.
Thank you, Dr. Han, for the kind introduction. Just checking if you can see the slides. And okay. All right. So this talk is going to be fairly practical, focusing on challenges we face in the clinical management of pancreatic cystic lesions. As most of you are aware, incidental detection of pancreatic cysts is year by year, we see more and more cysts in our clinics. Start up to 5% of CT scans and up to 25% of MRIs pick up incidental cysts in the pancreas, of course, of various sizes. And the thought behind is that so-called mucinous cysts, the most frequent of it is IPMN, can progress to pancreatic cancer. So if you look at the whole spectrum of pancreatic cancer, about 75 to 80% of this come from pancreatic intraepithelial neoplasia or PANN lesions, which is the solid adenocarcinoma, and then the remaining 15 to 20% are a progression from mostly IPMNs. Now, since the audience has a lot of GI fellows, nurse practitioners, so just a brief introduction that pancreatic cysts are divided broadly into mucinous cysts and non-mucinous cysts. Mucinous cysts are IPMNs and mucinous cystic neoplasm. Non-mucinous cysts have two tumors which can progress to malignancy, which is cystic neuroendocrine tumor, which is actually a kind of a degeneration of a solid neuroendocrine tumor to become cystic. And then there is solid pseudopapillary neoplasm. And the two benign entities are pseudocystadenomas and pseudocysts. Again, brief introduction into mucinous cysts. IPMNs are the most common we encounter in clinical practice, equal incidence between men and women. And we usually, they're incidental around 6 to 7 decades of life, and a majority of them are seen in the head of the pancreas. The other key features of IPMNs are they tend to be multifocal. And a point to be noted is that there are 3 flavors, which is just in the branch duct, just the main duct, or involving both branch and main duct, which is the mixed type of IPMN. These progress to adenocarcinoma, going through different stages of dysplasia. As far as mucinous cystic neoplasms, they're almost exclusively seen in women, about 95%, and also almost exclusively seen in the body and tail of the pancreas. Generally incidental around 4 to 5th decade of life, and they tend to be associated with chronic inflammation. Patients can have preceding pain, or they could be symptomless and incidentally found on scans. They also progress to adenocarcinoma. These are the 2 mucinous cysts, and the 2 non-mucinous cysts with the malignant potential are cystic neuroendocrine tumor, equal between men and women, which is, as mentioned before, secondary cystic degeneration of an otherwise solid tumor. On imaging studies, especially on CTs, they have a very prominent wall, and EUS, we can see kind of a prominent vascular wall. And the diagnosis is by FNA, fine needle aspiration with immunostaining. As far as solid pseudopapillary neoplasms, again, another cyst which is almost exclusive in women. They typically tend to have a mixed solid cystic appearance, and incidentally around second to third decade of life. And both these lesions, when detected, and especially if cystic neuroendocrine tumors are functional or more than 2 centimeters, they need resection. The two benign lesions are the serous cystadenoma, which is a neoplasm, but has less than 1% risk of malignancy. And of course, pseudocysts, which are benign inflammatory following acute attack of pancreatitis. Serous cystadenomas, it's more common in women than men. Incidental around 5th to 6th decade of life, equal distribution between head versus body and tail, typically described as a stellate scar on CT and even on MRIs, and most of them tend to be microcystic, but the macrocystic or the unilocular or oligolocular cysts tend to be a clinical challenge when diagnosing this cyst. So the traditional diagnostic evaluation of pancreatic cystic lesions includes cross-sectional imaging with CT and MRI, and EUS when indicated with fine needle aspiration. When you aspirate cyst fluid CEA with a cutoff of 192 and above has an accuracy of 65 to 70% in diagnosing mucinous cysts. Cytology alone, that is detection of mucin, or using cytology to diagnose neuroendocrine tumor or solid pseudopapillary neoplasm, has an accuracy of 50 to 60%. Generally, much higher accuracy when you want to achieve a diagnosis of neuroendocrine tumor or pseudopapillary neoplasm. Cyst fluid CEA with cytology has an accuracy of 75 to 70%, 70 to 75%. This is when you're trying to differentiate mucinous versus non-mucinous lesions. So if you take evaluation of pancreatic cystic lesions, you have the first differentiation, that is mucinous versus non-mucinous lesions. Here with standard practice, that is cyst fluid CEA and cytology, you have an accuracy of 60 to 70%. But the crux of the problem is actually risk stratifying IPMNs, because they are more frequent in clinical practice, and invariably about 40% of IPMNs resected across major institutions have low-grade dysplasia, which could have been possibly not resected. With the current available standard of care, the accuracy to differentiate just based on dysplasia is 50% or less. So there is a need to use novel techniques or improve current diagnostic methodologies. So because of this issue with diagnosis or challenges in diagnosis, there have been various guidelines across over the last decade. The most commonly followed guidelines are the revised international consensus guidelines, it's 2017, and the American College of Gastroenterology guidelines from 2018 is also commonly followed by many endosonographers. Here, briefly going through the high-risk features as per the international consensus guidelines: dilated duct above 1 centimeter, you have obstruction of the bile duct causing jaundice, or there is a nodule which is enhancing and measures more than 5 millimeters. A quick review of the worrisome features on the international consensus guidelines includes a dilated duct, but not more than 10 millimeters. And then you have history of acute pancreatitis, presence of a nodule which is less than 5 millimeters or non-enhancing on MRI, change in caliber of the pancreatic duct, or an enhancing cyst wall, and a size more than 3 centimeters. As of 2017 revised guidelines, they updated these worrisome features with the addition of 3 new features, which is presence of lymphadenopathy, CA19-9 above, elevated CA19-9, and more importantly, in my view, a cyst growth of more than 5 millimeters every 2 years. Now, in addition to the diagnostic evaluation, which is the standard of practice, we, at least at Ohio State University, we have added cyst glucose because it's economical and also based on the data which is available. Of course, cyst fluid glucose mostly helps with differentiating mucinous versus non-mucinous, so it doesn't give you a specific cyst diagnosis, or it doesn't help you with risk stratification of IPMNs. But as per multiple prospective studies and a recent meta-analysis, a value of less than 50, that is a low glucose value, is predictive of a mucinous cystic lesion. Now, when you combine that with CEA, your accuracy to differentiate mucinous versus non-mucinous cystic lesions goes from 65 to 70% all the way up to 90%. So as far as looking at the economics of it, this is a very valuable test to add if your facility is doing the standard practice, which is cyst aspiration, CA, and cytology. As I mentioned, this is not going to help with diagnosis of specific cystic lesions or with the risk stratification of IPMNs. Now, as far as indeterminate pancreatic cystic lesions, I would broadly say that it's where you cannot effectively classify a cyst as a low-risk non-mucinous lesion, which includes pseudocyst and pseudocystadenomas, because they don't turn cancerous, and or the detection of neoplastic cells, neoplastic non-mucinous cells with malignant potential, which is cystic neuroendocrine tumor and pseudopapillary neoplasm, or diagnosing high-risk mucinous lesions, which is IPMN and mucinous cystic neoplasms. Now, IPMNs, again, we had that brief discussion. We really have to try to focus on resecting IPMNs with high-grade dysplasia and try to just follow those with low-grade dysplasia. So essentially, indeterminate pancreatic cystic lesions are where you cannot arrive at a conclusive diagnosis of the cyst type, which with current practice is challenging. So here are some examples. These are real patients we have encountered in the last 1 to 2 years. Here is a patient with an isolated cyst. So an isolated cyst without clear evidence, without clear communication with the main duct, or when it's a single cyst, that's not a multifocal cyst, can be challenging. And here is a cyst which is unilocular, and the pancreatic duct can be seen here in this MRI. And upon further diagnosis, which is here is EUS, again, a unilocular cyst, thin wall, no mural nodules. So these are pretty challenging when we see them in clinical practice. Here is an evaluation. We did CEA, which was low at 0.5. Cytology did not show mucin. And next-gen sequencing did not show mutations. Of course, we use novel technologies, which includes next-gen sequencing and endomicroscopy. And endomicroscopy showed a characteristic Fern pattern of vascularity. So diagnosis here was pseudocystadenoma. Of course, the CEA also points towards the correct diagnosis. Another challenging scenario is which we encounter in clinical practice, is that the patients cannot recollect or just fail to recollect prior history of acute pancreatitis. It could be 20, 30 years back. Patient had an episode of pancreatitis and developed a pseudocyst. And lo and behold, patient has a CT for some reason, and then we find a cyst. And here's an example. So 37-year-old man with a 6 centimeter cyst, and we did EUS, and here is the EUS. It's unilocular. At the bottom, it could be argued that the wall was slightly thick. CEA was low at 10, amylase was 65,000, and cytology did not show any mucin. And here, endomicroscopy showed epithelial bands, and the eventual diagnosis was a mucinous cystic neoplasm with low-grade dysplasia. So it could be argued that patient could have had a pseudocyst, and further, this was a man instead of a female, where mucinous cystic neoplasms are more common in women. So these, again, just an example that such are the challenges with diagnosing cystic lesions. Here is another common problem which we see, mucinous globule. This is commonly seen in IPMNs, but also can be seen in mucinous cystic neoplasms. But many a times, if you are not careful, you may falsely label these mucinous globules as mural nodules and unnecessarily submit a patient for pancreatic surgery. Here is a 2.6 centimeter lesion with a mucinous globule. They tend to have a very hypoechoic or anechoic center with a hyperechoic rim or a whitish rim. And sometimes when you sample that with the FNA needle, you can actually disturb the mucinous globule or try to move it around. And sometimes they don't break up with the FNA needle. Here in this example, though, this patient had a mucinous cystic neoplasm with low-grade dysplasia. So the other challenge is, here is an MRI, which shows what looks like a microcystic lesion. So microcystic lesion is a common term for serous cystadenomas. And when we do EUS, we tend to see the so-called microcystic appearance with multiple septations, which is also characteristic of serous cystadenoma. Now, if you talk to some of the the older EUS teachers, they say once you see a microcystic lesion on EUS, you can just label that as serous cystadenoma, and there is no need to sample it. And this is, in fact, when I did fellowship, advanced fellowship, 8 to 9 years ago, that's what I was taught too. But what we have found in our experience is that not all microcystic lesions tend to be serous cystadenomas. So here is a patient, 4 centimeter on MRI, classically described as a microcystic lesion. And we did EUS, and also it had the similar appearance of a serous cystadenoma on EUS, but FNA showed a CEA of 572. We did add, as I said, we have added cyst glucose. Glucose was less than 10. And NGS, that's next-gen sequencing, showed KRAS and GNAS mutations, and microscopy showed papillary structures with a rather thick epithelium. And we referred this patient to surgery. So again, diagnostic challenges in pancreatic cysts. So the other thing is that when you see cystic neuroendocrine tumors, the CT scan, typically you expect to see that this is a well-circumscribed cyst with a nice thick wall. On EUS, you can also appreciate this wall. But this appearance can also be seen in pseudocysts and also with mucinous cystic neoplasms. So here is a patient with a 3 centimeter cyst, and CEA is low at value of 1, and cytology showed neuroendocrine tumors. So, but just given the imaging appearance, it's very difficult to conclude as to what type of a cyst it is without diagnostics. So, and other challenges are as far as the dilation of the pancreatic duct in reference to where the cyst is located. When we refer to the pancreas, everything below towards the ampulla, we call it downstream, and towards the tail, we call it upstream. So in case here is a cyst, this part of the duct is downstream from the cyst. This part of the duct is upstream from the cyst. And then, of course, the part of the duct which is adjacent to the cyst is, which is kind of adjacent to the cyst, meaning if there is dilation extending downstream and also adjacent to the cyst, these tend to be commonly seen with the mixed type of IPMNs, where you have a cyst and there is adjoining dilation of the main duct. It can also be seen in patients with chronic pancreatitis and with pseudocysts. Now, if you have upstream dilation, that is towards the tail, this could still be a mixed type of IPMN, but could be an obstruction of the duct by a mucinous cystic neoplasm. Could also be seen in chronic pancreatitis. If you have a pancreatic dilation of the main duct, could still be mixed type of IPMN with cysts in the pancreas, and also could be chronic pancreatitis with prominent side branches. And other common scenarios which tend to be a challenge. Now, this is basically focusing on each type of cyst and what are the common challenges we face with these cysts. As far as mucinous cystic neoplasm, as I mentioned, they are more common in body and tail, and the CEA is least reliable in these. And many a times, because they have areas of denuded epithelium, where they lack epithelium, nearly 30 to 40% of this can lack a true epithelium. Because of that, they tend to not give up DNA, and next-gen sequencing can have a lower sensitivity, specifically for mucinous cystic neoplasms. And further, when you kind of put pseudocysts versus mucinous cystic neoplasms, both these patients with this cyst both can present with preceding pancreatitis or ongoing pain, and especially if the patient is smoking, it's a diagnostic dilemma. And both can have intracystic debris or intracystic inflammatory material, and both the cysts can have thick walls. And as far as serous cystadenomas, they are, as I mentioned, they are challenging when they are macrolocular. Typically, these are microcystic or multicystic. And rarely they are unilocular or macrolobulated. They tend to be challenging to diagnose. And although differentiating branch duct IPMN versus mucinous neoplasm doesn't change management, yet sometimes arriving at a specific cyst diagnosis is challenging when the branch duct IPMN is located in the body and tail, is isolated, does not have a communication with the main duct, and when it's not multifocal in the pancreas. So the other rare type of cyst, which is lined by a squamous type epithelium, which is the lymphoepithelial cyst, they consist of a very heterogeneous group of cysts. Invariably, they tend to give a high CA value. Again, challenges in diagnosis. You might falsely label them as a mucinous cyst and submit the patient to surgery. Truly, they are tough to diagnose specifically, and many a times cytology can see this material where they can come to an accurate diagnosis. Another rare type is when you have metastatic lesions to the pancreas, which undergo cystic degeneration, giving rise to cystic lesions. Typically, patients do have a primary cancer. These are rare, and cytology is very helpful in diagnosis. So, along with the traditional cyst fluid CA and cytology, we have the addition of cyst glucose, which is economical, and depending on the center and the expertise in specific facility, you can have novel diagnostics, which includes cyst fluid molecular analysis, EUS-guided needle-based confocal laser endomicroscopy, and EUS-guided through the needle microforceps biopsy. I'll briefly discuss these novel techniques since they are highly facility dependent. For cyst fluid molecular analysis, it's aspiration of the cyst fluid with a standard 22 gauge needle. You don't need to use a larger needle. Overall has very high accuracy for diagnosing IPMNs, and also adequate accuracy for mucinous cysts. When you look at the sensitivity for mucinous cysts in this meta-analysis, it goes down a little bit just because MCNs tend to pose a challenge when using NGS for diagnosis. Challenges with cyst fluid molecular analysis, the center has to know how to handle biospecimens. They need to discuss insurance coverages. It's not available at all academic centers, and the commercial tests are very expensive compared to the ones processed at academic centers. Endomicroscopy is real-time endoscopy-guided microscopy, which lets you do a virtual biopsy of the cyst. And here we use a processor. There is a probe which is preloaded in 19 gauge needle. So here we require a larger bore needle, which is introduced to the cyst to produce real-time imaging. Here we see the characteristic papillae seen in IPMNs. So each of the cyst type has specific image patterns, and there is a stepwise stepwise approach to arrive at the correct diagnosis. There are not that many types of cysts, so there are only about 4 or 5 very characteristic patterns which can be seen during endomicroscopy, and including our single center study and multi-center study from France has shown higher accuracy for differentiating mucinous and non-mucinous lesions. And there is a recent meta-analysis also showing a higher sensitivity and specificity in differentiating mucinous and non-mucinous cystic lesions. And the next step, the next kind of the diagnostic evaluation using endomicroscopy is differentiating IPMNs with low-grade dysplasia versus those with advanced neoplasia, which includes high-grade dysplasia and cancer. The 2 key features which we have observed are the thickness of the epithelium in the papillae of the IPMN and also the darkness of the epithelium, both of which increase with advanced neoplasia because of the stratification of cells and nuclei. The challenges with endomicroscopy are that there is training involved, and most of these practitioners are status post advanced endoscopy fellowship. So it's not only you have to train them in technique, but also train them in image interpretation. Most of us don't have the patience. We are used to instant gratification when we do endoscopy. When you look at the mucosa with the standard scope, but with endomicroscopy, there is a lot of patience in trying to get optimal imaging. Further, the equipment is not cheap, and the interpretation can be prone to intra-observer variation. The new device is through the needle forceps biopsy. where we use again a larger needle, which is the 19-gauge needle, and we use this microforceps biopsy. And the diagnostic yield is better than the standard of care, which is ranges from 70 to 80%. And the key issue with this is it does limit the range of motion. That's the intracystic reach. And there are challenges with tissue adequacy, and the technique has to be standardized. But the biggest issue is the risk of acute pancreatitis and intracystic bleeding. In these two meta-analyses, the risk of acute pancreatitis ranged from 5 to 6%. And there have been reports of even a mortality. One patient died in a prospective study from Europe following cyst microbiopsy in a patient with an IPMN. So unless you kind of have some kind of experience using 19-gauge needles and experience in this, I would be a little hesitant to recommend this given the safety data. So here is a slide which compares all the 3 advanced diagnostics with their strengths and weaknesses. I just don't want to go into details of all this, but generally, cyst fluid molecular analysis using a 22-gauge needle has almost zero risk of acute pancreatitis, is perhaps the safest technique. Going on to endomicroscopy, where we use a 19-gauge needle, there is a little increase in the risk of acute pancreatitis, 2 to 3%. With the microbiopsy, it goes up to 4 to 10%, also includes intracystic bleeding. The key aspects of managing indeterminate cysts are: 1, a good history. Get to know the demographics, the cyst morphology and imaging, and a thorough clinical evaluation. This is baseline critical necessity. And the next most important step is get all the scans you can. Generally, these patients are referred to your center. You really have to struggle hard and get all the prior scans. It's highly unlikely for a neoplastic cyst to grow within a span of months. It doesn't appear out of nowhere. So if it appears out of nowhere, probably the patient had an episode of acute pancreatitis. So if you are managing mucinous cysts, you want to get all the prior imaging to look at the rate of growth, which is a critical determinant of predicting advanced neoplasia. So also you want to look at changes in cyst morphology. Is there a mural nodule which was not there and it has appeared in the last 6 months during follow-up? Discuss all these imaging studies with the radiologist. A typical setup is if you have a multidisciplinary meeting where you can review all the scans and get the radiologist's opinion. And a serious consideration when you are doing standard of practice is addition of cyst glucose, given the low cost. But one caveat is that you just cannot add in cyst glucose. You have to engage your lab director, and you have to standardize this, or you have to validate this in a specific lab. It may take 10 samples, and then it can be added on as a standard lab to your EMR, that's electronic medical system. And if your center doesn't do advanced diagnostics, if you have a challenging cyst, please consider referring that patient to a center specialized in doing advanced diagnostics. So in conclusion, pancreatic cystic lesions are increasing in prevalence, at least at a tertiary care center specializing in managing pancreatic cysts. Indeterminate cysts are common in clinical practice. I do recommend adding cyst fluid glucose, very useful in small cysts when you're trying to differentiate mucinous and non-mucinous, very economical as well. And advanced diagnostics are purely based on center expertise, where we get a comprehensive evaluation. We can come to a specific cyst diagnosis, and so also estimate the risk of malignancy by detecting advanced neoplasia. And as a practice, we review all our challenging cysts in multidisciplinary meetings. Thank you.
Thank you, Dr. Krishna, for that. And with that, we will begin our Q&A session. As a reminder, please type your questions in the chat section, and that allows us to be able to get to them. Dr. Tavakoli, we'll start with some questions for you. Thank you for joining.
Hey, how are you? Sorry I was late.
Oh, absolutely, no worries. The first question for you comes from Dr. Singhi from UPMC, and he was wondering if you could comment on the risk of pancreatic adenocarcinoma among patients with germline alterations associated with chronic pancreatitis, such as PRSS1 and SPINK1.
Yeah, so patients with underlying genetic mutations, from my understanding, is they have a higher than normal risk of developing pancreatic adenocarcinoma. And a lot of times in the consortium studies, they look at these patients as kind of patients to follow in terms of risk, because they'll have increased episodes of pancreatitis, and they can kind of follow and see what their natural history is in terms of pancreatic cancer. But yes, they do have a, as far as I know, and somebody can correct me if I'm wrong, a higher risk than normal baseline for pancreatic adeno.
And then the second question for you is coming from Dr. Gorbanova at Seattle Children's, but she's wondering if she's stating that it's interesting that hyperinsulinemia is thought to be a possible driving factor for pancreatic cancer, yet type 3C diabetes is known to occur before pancreatic cancer, and it's a state of insulin insufficiency.
Yes.
Any thoughts on that?
So that is correct. Based on studies looking at patients with both diabetes and without diabetes, it seems like insulin resistance and hyperinsulinemia are key mechanisms in terms of that may drive pancreatic cancer. Type 3C diabetes is considered to be something that's caused by pancreatic cancer. There is some literature that it shows that pancreatic cancer may also cause like a perineoplastic cause of diabetes as well, which I think is still kind of trying to be teased out. So it may not be as simple as type 3C causing, or pancreatic cancer causing a type 3C diabetes.
And a question from myself regarding pancreatic cancer screening. So you mentioned in your talk how at this time we don't really have great evidence to support pancreatic cancer screening. But at the same time, there's so many of these patients, like we've all had patients with chronic pancreatitis who eventually develop, pancreatic cancer, and then patients who have had basically preceding diabetes, and then they develop pancreatic cancer within a couple of years. And so obviously you mentioned the CPTPC study and kind of those prospective studies going forward. But if you, for example, let's say you had a patient with a positive family history and that drives you to kind of want to do some screening, what kind of screening modalities would you start with?
Typically here we get MRs. So we have a high-risk genetic mutation or high-risk genetic protocol for patients here with family history. I'll be the first person to admit that, these patients are really hard, and oftentimes once they present to the clinic, they're patients who may have a little bit more desire to undergo screening. So it becomes very difficult to tell them that, oh, I'm not going to do an MRI, I'm not going to do, XYZ. But at the same time, it's hard to ever see anything. I tell them the pros and cons, and by the time they come to clinic, they want to undergo the screening tests.
Great, thank you so much, Dr.
Thank you.
Dr. Krishna, the next couple of questions are for you. Dr. Shalabi from UPMC was wondering about the utility of the Moray microforceps in the diagnosis of cystic lesions.
So as I mentioned in the talk, that they do have a higher risk of acute pancreatitis across multiple studies and meta-analysis. But some single center studies do report lower risk of acute pancreatitis of less than 2%. So it is operator dependent, but more commonly though, they can cause acute pancreatitis. We have used it here as well. And generally my experience has been that once in patients with mucinous cysts, IPMNs, it tends to cause pancreatitis. It doesn't take much to cause pancreatitis in those cystic lesions. It's fairly safe to use in serous cystadenomas. So while we kind of use a multimodal approach for diagnosing pancreatic cyst, here, since it's convenient to get a tissue sample, we do use it for some serous cystadenomas when diagnosis is in question. So I cannot speak for all endosonographers, but personally, I reserve it specifically for serous cystadenomas. For whatever reason, serous cystadenomas generally never get pancreatitis, even with a high degree of instrumentation.
Thank you, Dr. Krishna. The next question from you is coming from Dr. Singhi from UPMC, and he was wondering about how you deal with growing serous cystadenomas, and are there any imaging features that would be concerning for you?
So We had a couple of serous adenomas in our single center study, which grew rapidly at a rate of more than, at least I would say, centimeter over a year, or 2 centimeters over 3 years or so. And they kept, repeat FNA did not show anything suspicious. Repeat, even core sampling did not show any. So imaging techniques also did not show any suspicious features. But eventually, decision was taken for surgery after a multidisciplinary conference, and both, one was 8 centimeters, the other was 10 centimeters, and both showed serous adenocarcinoma. So the rapidly growing ones, I think they tend to probably have cancer, but luckily, I think even if they turn malignant, they tend to have a very good outcome after surgery.
Great. And then his follow-up question was also regarding the use of NCLE, or confocal laser under microscopy, and this may be controversial, but he was wondering if you can use it when you enter the main pancreatic duct.
So as far as using the FNA needle itself, using a 19 gauge needle in main duct, I'm pretty sure will result in pancreatitis, bleeding. So we tend to not do that, but there is a cholangioscopy probe, which is the endomicroscopy probe used for bile duct, that can be used in main duct. We did use it before the second generation of spyglass came about. We, through the standard sphincterotome and going into the main pancreatic duct to kind of estimate the amount of involvement of IPMN, main duct IPMN. But with the next generation of spyglass, our visualization is so good that I think the endomicroscopy takes a back step. We hardly used it in the last 4 or 5 years since we had the second generation of spyglass.
Thank you, Dr. Krishna. And the last question is from me regarding, so oftentimes it's, especially with the smaller lesions, it's hard to get a lot of fluid to send for all these studies. And so you mentioned getting, for example, if your center has it, sending it for molecular analysis, and then also now the cyst glucose, as well as cytology and also CEA levels. But roughly how much fluid do you think you need at a minimum to be able to actually send for all those studies, especially if they're going to be kind of in separate jars?
So if you get 0.5 or less, I would prioritize next-gen sequencing over all the other tests if your facility has it. For CEA and glucose, as per our lab, we don't need more than 1 ml. So if your facility cannot do next-gen sequencing, if you can manage 1 ml of fluid, you can send that both to CEA, send that to CEA and glucose. Amylase has no value, and cytology will come next after CEA and glucose. And cytology, they can manage with whatever you give them. So overall, 1 ml for basic workup and 1 to 2 ml if you want to add NGS and cytology.
Great. And we just got a last minute question about the use of contrast enhanced EUS, if anyone is using that.
We do not use it at our center. And recently I did do a review. It was a great technology for cystic lesions. Initially, there was a lot of talk about it, but I think the last 4 to 5 years, there has not been many studies looking at it. Since I don't have specific interest in that, I have not really dwelled on that topic. So,
gotcha. Well, with that, I really want to thank our 2 speakers, Dr. Tavakoli and Dr. Krishna, for speaking today. Those were fantastic talks. We really appreciate that. And as a reminder to everyone, please complete the post-test. And again, we are having these series every Thursday, so tune in next Thursday at the same time as well. All right, thank you very much, everyone. Have a good night.
thank you.